Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast episode. And today with me is a good friend and fellow NEI faculty member, Dr. Jeffrey Strawn. And we're going to be talking about OCD, which, Jeff, that's a topic we just don't hear enough about, I guess because a medicine hasn't been FDA approved for OCD in many years.
You're absolutely right, Andy. And I think there are a lot of reasons why we don't hear about OCD, probably as much as we should. I think that it often gets eclipsed by some of the other disorders that we often focus on: depression, bipolar disorder, schizophrenia, and even now more so the other, what we used to call anxiety disorders.
Yeah, that's a good
point. Remember,
OCD
was kicked off the anxiety disorder island when we went to DSM-5.
It was, along with PTSD, but to me, there'll always be anxiety disorders to some degree. I'm guessing OCD is more common than most people listening realize. How common is it, Jeff?
It is actually pretty common. When we think about the actual prevalence, we think generally about 1% to 2% of the general population. And as a reference, when we think about individuals with what we call the non-OCD anxiety disorders, or what we used to call the non-OCD anxiety disorders, meaning generalized separation, social anxiety disorder, we may be thinking more in a 5 to 7% range. To your point, Andy, I think underdiagnosis is also a real concern. I know that we often miss OCD in populations where it presents atypically. So, for example, I'm also a child and adolescent psychiatrist, and in those situations, oftentimes what we'll see is that the OCD symptoms are actually mistaken for more common either developmental anxiety or other developmentally related phenomena. The other piece is that they may be in children attributed to behavior or oppositional types of symptoms. Now, in adults, I think we miss the diagnosis for other reasons. And I think the biggest reason there is that really comorbidity kind of clouds that picture. So OCD is pretty frequently accompanied either by depression, or I would say probably also by something that looks like depression, demoralization. But it can also be accompanied by the other non-OCD anxiety disorders that we were just talking about. So when one disorder kind of, if you will, really dominates the clinical narrative, we can overlook these OCD symptoms. So oftentimes this is about learning that the OCD is actually hiding in plain sight for many of our patients.
Yeah, I think that's true. And I'd be willing to bet it's probably a little more common than that classic prevalence you cited for some of these reasons. And that plus people are embarrassed, or they don't know that it's a treatable condition. They don't seek help. And I don't think a lot of us have been well trained to recognize it, as you're saying. So there's a lot of reasons that it's going to be missed or underestimated. And I'm sure there's also a lot of overlap, if you will, or there's a spectrum, like you said, with OCPD, or obsessive-compulsive personality disorder, and OCD as a separate disorder.
Absolutely.
How do we sort that out?
Yeah, so again, I think one of our best diagnostic tools that we have is time. And oftentimes these patients are not necessarily presenting in as much of a crisis as we might see with that patient presenting in a major depressive episode, or certainly in mania or a psychotic decompensation. And so oftentimes what I find is that really disentangling OCPD from OCD or obsessive-compulsive traits is best done over time. I think there are a couple of reasons for that. One is that it allows me to get to know the patient a little bit better. It also gets me the opportunity to understand a little bit more about what's going on in their life, which then allows me to have more opportunities to ask about maybe something that smelled a little bit like OCD initially, but wasn't endorsed in that classic phenotype.
I wonder too, Jeff, could OCD be an underlying cause of what we might call treatment-resistant depression or treatment-resistant anxiety?
I think it actually could. And this is something that I was really hoping we'd talk about, which is what are those kind of trickier presentations of OCD, and how does that really, unfortunately, cause us as clinicians to misdiagnose many of these patients. And this is something that, as I was thinking about this upcoming podcast, I was actually thinking about a patient that I've been treating over the last year, because I think this idea of missing OCD because of what may be secondary depressive symptoms or secondary anxiety symptoms is probably more common than what we might think. So this man that I recently treated was in his mid-20s, and he came to me initially for treatment-resistant depression. Now, this is someone who, again, depending on the criteria that we use for treatment-resistant or difficult-to-treat depression, may meet some criteria, may not meet others, but I think that's beside the point here. He'd had an initial course of escitalopram, which he didn't tolerate because of some activation, worsening anxiety, worsening insomnia. Again, he was endorsing a lot of symptoms of depression. He met criteria for major depressive disorder. And what I did was to switch to vortioxetine, and really we weren't getting much improvement there. Now, I had recognized that there were some obsessive-compulsive traits, but I think I probably attributed these more to, that anxious rumination that we often see going along with depression. So we augmented what were probably at the time almost near classic depressive symptoms with a little bit of aripiprazole. And there was some partial improvement, but I think what really helped me out in this case is that I'm still a child psychiatrist, and so oftentimes patients are coming in with their family members, and I'm encouraging them to bring in family members, and we often are talking a lot with the therapists. And the parents had come in with this young man because they were very, very concerned about increasing suicidality. And the suicidality was really unusual in that it wasn't that classic depressive suicidality. It had a really ego-dystonic flavor to it. And I think that's something that's very, very important in terms of a clue that perhaps maybe we should have picked up on earlier, because this is a gentleman who was ruminatively thinking about getting a gun and access to firearms and whether or not he would kill himself or die by suicide, but he did not want to die. And so what we did is we really started working more with these symptoms as we started to uncover a lot of other intrusive, compulsive, symptoms. And this is a young man who had just become demoralized by the magnitude of his OCD symptoms, and it was affecting relationships and other things. Now, we were able to, in a very slow process, cross-titrate over to fluvoxamine, and then, over the course of several months, taper off the aripiprazole, and he's doing wonderfully now just on fluvoxamine monotherapy, and has actually completed a course of a really good exposure-based cognitive behavioral therapy. But I think it's important to go through a case like this because it really illustrates how the OCD just hides in plain sight.
That's an excellent example. And you were able to get him off of the aripiprazole too, it sounds
Absolutely.
Like. That's fascinating. I'm going to talk about treatment in a minute and a possible role for antipsychotics, but I also want to mention another way it may be missed. I'm thinking back to a patient I saw early in my career who his obsessions were really bordered on delusional. I mean, they were a little strange in a way. There was a strange flavor to them. And I can imagine that sometimes people may be misdiagnosed even with a psychotic disorder of some type or other. So another way it's sort of hiding, I guess, in plain sight.
I think that definitely happens. Absolutely, Andy.
Yeah. All right. Well, let's talk about now maybe a way to think about assessment of a patient. What's kind of your go-to way to think about how would I do an assessment of a patient who might possibly have OCD?
So in terms of thinking about that patient, certainly when they're presenting, we go through our standard assessment in terms of thinking about depressive symptoms and screening for a history of bipolar disorder or even hypomanic symptoms, as well as kind of the other broad DSM buckets. But when we're thinking about OCD, I think the most important thing probably for our listeners to remember is that this is a disorder of ego-dystonic thoughts. So as we're talking about these symptoms, they're oftentimes going to feel very alien. They're going to feel very intrusive. Now, I tend to ask a lot about the nature of the thoughts that they may be having when we're going through OCD type symptoms. So are these thoughts that are repetitive? Are they distressing? And then what accompanies them? Are there behaviors or are there rituals that they're doing to relieve the anxiety created by that obsession? The other thing that I think is really important, and I'm hoping we get into this a little bit later in the podcast, is looking at insight. Because insight is one of the most important prognostic factors when we're thinking about OCD, and even so important that DSM recognizes it with a specifier. Coming back to what we were saying maybe just a few minutes ago, time is really a diagnostic tool. And I think this is where it's not just a one and done assessment of OCD symptoms, but really coming back to it. The reason for that in particular is that oftentimes there's a lot of shame or guilt about these obsessions, and especially when we're talking about things that maybe involve sex or religion or harm. I had another patient that had a very intrusive thought that they would push someone down the stairs. And this is something that, despite having asked about other obsessive and compulsive symptoms, for 6 months, didn't come out until much later in the course of treatment. So again, I think it's important to, as always, kind of normalize many of the symptoms using language like sometimes patients will experience or sometimes people will feel. Mm-hmm. Is that something that is familiar for you?
Yeah. I think, like you said, too, if a patient is not getting better with whatever you're doing, you always want to be thinking what else could be going on, and this could be one of those things.
Right. So right treatment, right diagnosis, right time.
Yeah. Can we go back to insight for a minute? What exactly do you mean by insight in the setting of OCD?
So when I'm thinking about insight, I'm really looking at a couple of things. One, I'm looking at, is there an awareness of the fact that these are symptoms? Two, is there an awareness of the fact that these symptoms may be impacting function or relationships or work or other activities? And the third part really for insight is there some ability to attribute these symptoms or these behaviors to something treatable?
And what do you find in working with these folks? Do you find that they often have insight, or is it a 50-50 thing? Is it something that they can learn to have insight?
I think it is something that some patients will get more insight over time, particularly as they're working in the psychotherapeutic treatments. I think sometimes it's also an issue of just not having the appropriate vocabulary, being able to recognize that these are in fact symptoms. I thought these were just behaviors, or I thought these were just things that I do. And so being able to really provide a modicum of probably psychoeducation can actually be really important in terms of building insight. I think the other thing that is important here as we're talking about insight is that it's probably not an all or none. This is probably something that exists on a continuum, and it may fluctuate over time as well.
Yeah, I would think with stress, the symptoms and all of the aspects of this would fluctuate. My experience is that this is not the same kind of problems with insight that we see with schizophrenia or bipolar disorder, which are really global and pretty pervasive. But there may be some deficits in insight, but that they can get better over time, as you're saying.
I think you're absolutely correct, Andy. And when I think about the impairment in insight that may go along with a psychotic disorder, I almost think about that as more of an anosognosia,
exactly.
As opposed to, something that is less, as you put it, global here when we're talking about OCD.
Yeah. Now, I know not everybody uses screening tools or rating scales, but are there some screening tools, structured interviews, rating scales that would be helpful?
This is one of the things that's really perplexing, because when we think about the amount of screening tools that we have for anxiety and depression and bipolar disorder, we have multiple options on the buffet. It's pretty limited when we're talking about OCD. That being said, if I do have a patient with OCD, I think that there's incredible value in terms of using something like a PsyBox or a Y-Box. So the Yale-Brown obsessive-compulsive inventory. And that's generally divided into the obsessions and the compulsions. And one of the reasons why this is probably one of my favorite tools is that it actually not only assesses the severity, but also frequency and impairment associated with those symptoms. And one of the things that I'll actually do if I'm treating a patient with OCD is we'll incorporate that into our time together. This is not something that I would have the patient do in advance. It's something that we'd actually look at together. And I think there's something very collaborative about that process.
Yeah, I've done a couple of clinical trials for OCD, and I've used the Y-Box, the Yale-Brown obsessive-compulsive scale. And I agree with you. The organization of it is wonderful. I think it's a little cumbersome to use in practice, but I think you're right. The concepts of assessing the obsessions first, then the compulsions, and within that framework, looking at frequency, severity, impairment. I think that can be done, and especially if you get a good grounding, a baseline grounding in what the specific kinds of obsessions and compulsions are, because they can really vary. I've been really struck by how there are certain themes that are common, as you've mentioned a few of them already, but boy, within that universe, there can be some very specific and unusual kinds of things.
Absolutely. Absolutely.
Yeah. Yeah, we talked a little bit about the non-classic. I kind of like how you said that, the non-classical presentations, because I think we all kind of have in our mind a certain kind of presentation. So I think one of the things that we're going to do with this podcast, hopefully, is just raise awareness that there's not just sort of one presentation here. Well, let's say now that somebody is really strongly suspecting or even diagnosing OCD. Let's talk about the categories or classes of treatments. What are the most common forms or the best evidence-based forms of treatment?
Broadly speaking, when we're thinking about treatment for OCD, we can think about the psychotherapeutic interventions, so classically CBT and probably a special flavor of CBT. We'll put that on the shelf, though, for a moment. Then we think about pharmacotherapy, but I think another thing that we're now increasingly realizing is that there are alternative treatments. So certainly we have TMS, which is FDA cleared for treatment of OCD. We have some evidence for other neuromodulatory interventions.
Hang on, I didn't realize that. So TMS is actually formally cleared by the FDA. I did not realize that.
Yeah, so it's a little bit different than the TMS that we use perhaps for depression. In that this is deep TMS. And what's interesting is it's actually paired with a psychotherapeutic intervention.
Okay, that is interesting. Yeah.
Now, I guess, when we're thinking about the medication treatments for OCD, we often think about the SSRIs. Again, we have several of these with FDA indications for OCD. And I think these are something that definitely can turn down the volume on the intrusive thoughts, and they can certainly attenuate some of that emotional intensity in that obsession compulsion cycle. But on the other side, the CBT that we have, particularly when it really includes that exposure response prevention, this is what ultimately helps train the brain, to develop a new pattern of responding to those thoughts. And so this is really a place where I think the combination treatment is pretty critical. And one aside here, I mentioned the type or flavor of the psychotherapy is really important. And oftentimes when we're thinking about anxiety disorders, and I'm actually bringing OCD back into the anxiety disorder fold here for a moment, we often focus on this coping and calming folks down and try to give these various coping strategies. But that's really not what is going to get someone with OCD better. And we have to talk about something very, very specific, which is the process that underlies a lot of the change that we hope to see in good CBT, and that is inhibitory learning. So the idea here is that it's not just about extinguishing a fear or discomfort, but what we want to do is we want to allow the patient to have more adaptive association. So in other words, instead of learning my anxiety will go away if I check the door 12 times, what the brain learns in good therapy is I can feel anxiety and not check the door and nothing bad happens. So we've essentially violated that expectation that something bad will happen if I don't do the compulsion. I think that's a really important piece, because when we look at these psychotherapy trials in OCD, they often don't bring in this type of work until relatively late. And we know this is where the rubber meets the road. This is really where the action happens.
Well, this is fascinating. You're making me think about neurobiology. And, we talk a lot about neuroplasticity. And I don't think we talk enough about there's probably good neuroplasticity and not so good neuroplasticity. And maybe OCD, like substance use disorders, is a maladaptive circuit, neuroplasticity, and maybe what you're talking about is a new form of neuroplasticity, sort of breaking the circuit and reconnecting a new circuit.
I think you're definitely onto something there.
Yeah, well, it's a theory. It makes sense to me. So you're talking about not just the exposure, but of course the extinguishing of the response or the prevention of the reaction to the exposure that's so critical here. That must take time to build up to. You can't just, sort of have someone jump into the pool all at once, I would think.
I'm going to push back there because I think that's what we've all been taught. That's definitely what I always believed. And this is where one of our other NEI faculty, Catherine Dalsgaard, has really helped me probably become a better therapist, or at least use some of these psychotherapeutic techniques when I'm with patients. Because I think we're often worried about making a patient's anxiety worse. And one of the things that sometimes can happen there is that we over-accommodate and that we move too slowly. Just as we might start with very, very baby doses of an SSRI and take months to get to an effective dose, I think we sometimes do the same in psychotherapy.
Yes. Okay, that's really helpful. You're right. Sometimes the best treatment is counterintuitive, so that's good to know. Now, clearly the FDA-approved treatments are largely serotonergic, and you mentioned a couple of SSRIs. Of course, there's the classic clomipramine, a tricyclic antidepressant. Can you remind us which SSRIs are FDA-approved for OCD?
Great point, Andy. So many of the SSRIs actually do have either data or indications for OCD. So to review, we have fluoxetine, which is FDA approved in children, adolescents, and adults, so individuals 7 and older with OCD. We have fluvoxamine, another one that has a pediatric as well as adult indication for treatment of OCD. And then we also have sertraline, which is approved down to the youngest age. So this is approved down to age 6 or greater. And certainly approved in adults as well. Now, paroxetine is approved for OCD, but only in adults, not in pediatric patients. And then we do have evidence for some of the other SSRIs, although none of the others have actually achieved an FDA labeling for treatment of OCD.
That's fascinating. So we do have medicines approved down to quite young ages for this, and I would think that OCD is something that probably starts in childhood or adolescence. Am I correct?
You're absolutely correct. For many patients, it does begin relatively early. Like most psychiatric disorders, aside from major neurocognitive, disorders and so forth, many of these conditions do emerge prior to patients being 18. And I think I'm always looking for the clinical importance of these things that we might talk about on a podcast. And so for our clinician friends who are listening, what that means is your patient who's presenting to you at age 18 or at 20 has likely been experiencing OCD symptoms. Their families have been accommodating for years prior to their first coming to treatment.
Yeah, that's certainly true. And this can be very disruptive to people's lives and relationships. I've certainly seen that. Now, you alluded to this earlier, that SSRIs, the effective doses, the evidence base is higher doses than we're used to for depression or anxiety conditions. So, but yet at the same time, in my experience, a lot of patients with anxiety disorders, and I'm not sure about OCD, Jeff, maybe you know, they don't tolerate higher doses right off the bat. You have to ease into it. Is that true here as well?
So this is where I'm going to maybe put on my child and adolescent psychiatrist hat again. I think this is now the third or fourth time I've put that hat on this podcast. But, you know, when we look at the OCD trials that are done in children and adolescents versus the SSRI trials that are done in the non-OCD anxiety disorders or depression, we find that there's very different tolerability. But I don't know that that's necessarily something intrinsic to the SSRI. When we look at the trial, so for example, the pediatric OCD treatment study, POTS, the dosing of the SSRI in this study, in this case it was sertraline, was really much, much faster than most of us as child and adolescent psychiatrists, and quite frankly, faster than many of my adult psychiatry colleagues would go. And I think we saw the cost of that, which was poor tolerability. So I guess to answer your question a little bit more directly, yes, I do go a little bit more slowly when I'm treating a patient with OCD, but at the same time, probably more so than the anxiety disorders, I am really trying to get to a target dose relatively quickly.
Much higher. Yeah, that's the point. You don't want to just use low doses and not eventually push up the dose. That's what's so critical here.
And there is a really cool study that looked at this in adults with OCD. And we have relatively few studies that have actually compared dosing strategies, you know, across depression, anxiety disorders, and OCD. But this is a nice one that was probably published about 15, 20 years ago at this point. It's a study looking at 2 dosing regimens of sertraline in patients with OCD. And what they found was that the higher dose of the sertraline was associated with greater improvement than was the lower dose, although again, there's no free lunch. So side effects were much higher in that group. But it has often made me wonder, when we're thinking about dose is not dose is not dose. So particularly when we're thinking about sertraline, that 150 milligrams in one patient might be the equivalent of 50 milligrams in another patient, depending on their 2C19 metabolism, their 2B6, so 2-bravo-6 metabolism, both of which influence sertraline.
Yeah. No, that's an excellent point, that the best dose is the dose that works for the patient and is tolerated. So I think we have to talk about really individualizing. Yes, there's sort of this clinical saw that you have to go very high or higher, but it really depends on the patient. Some patients are not going to, they're slower metabolizers or whatever. I want to talk about the difference between SSRIs and clomipramine. In your experience, have there been times when you've seen clomipramine work better? I'm not advocating for it first line, of course, but are there situations where an SSRI is inadequate and then switching to clomipramine can make a difference?
Absolutely. Absolutely.
Yeah,
and I agree with you that we wouldn't use
too.
clomipramine first line.
Yeah.
But this is something that I really worry about. If there's a way to make a public service announcement portion of this podcast, I think this is the time to do it. So I think as I get a little bit older or maybe more experienced, I am able to look back on, you know, what we currently have in terms of what our trainees are exposed to. And unfortunately, oftentimes they're exposed to SSRIs and then more SSRIs and then SNRIs and maybe some atypical antidepressants. But the problem is that we're not necessarily thinking about those, I'm going to use air quotes here, older medications. So things like the tricyclics, which can really be life-saving and really restorative or functionally restoring for many of our patients with OCD.
I completely agree. I have definitely seen clomipramine work better in some cases or better in certain patients. So you're right that we do need to help, especially, I mean, maybe for depression, okay, tricyclics may not be as commonly used, but I think for a situation like this, when we have much more limited options, it's really incumbent on us to learn how to use clomipramine appropriately.
Andy, I think that's something maybe we should spend a couple minutes talking about, because it's probably worth looking at why clomipramine has really earned its stripes in treating OCD. And there are probably a couple of reasons here for that. And you and I always love to kind of muse about receptor pharmacology and differences in potency and selectivity and so forth, that may subtend these differences in efficacy. And I think this is really a place where we can have some fun because, as we know, it's the most serotonergically selective of the TCAs. It is a potent inhibitor of 5-HT reuptake. The other thing that really is interesting here is that, as you know, and probably many of our listeners know, clomipramine has an active metabolite. So we have clomipramine, which is very serotonergically active, and then we have norclomipramine, the metabolite, which, if you will, adds a little bit of noradrenergic flavor here. So one of the other things that I think is probably really important to think about when we're talking about clomipramine is that, yes, we have this clomipramine and norclomipramine. I mentioned that there are differences in terms of serotonergic selectivity, but I think that's something that we have learned to exploit. Because one of the things that we know from some really eloquent studies that have been done is that it's the serotonergic mechanism that probably drives that improvement in OCD. And so one of the things that we will sometimes do when we're using clomipramine is we will add a little bit of fluvoxamine. So when we're adding that fluvoxamine, what we're actually doing is via that interaction with 1A2, CYP1A2, we're shifting the ratio so that we actually get more of the clomipramine relative to the norclomipramine.
I see. Right, because fluvoxamine inhibits CYP1A2, just to be clear.
Absolutely correct. Absolutely correct. Now, what's also important here is that whenever we're using clomipramine, there are a couple of things that we have to do. So if we go to the pediatric guidelines, we have to check EKGs prior to and after titration. And then we have the same recommendation for individuals over the age of 50 from the American Psychiatric Association. So this is one of those situations where I do recommend absolutely following the guidelines and getting an EKG. I think the other thing that's important here is that we need to probably be using therapeutic drug monitoring. So checking a clomipramine plus norclomipramine level, not just the clomipramine level, but getting both the parent drug and the metabolite level. And that can actually give us some useful information. First of all, as always, it tells us whether or not the patient may be taking the medication, but it also allows us to look at that ratio of the clomipramine to norclomipramine. And then, as I mentioned, that clomipramine level is really what we're looking at when we're looking at probability of therapeutic response.
I see. Boy, that's really helpful, Jeff, because we're not used to checking blood levels for SSRIs. I don't know that that's as clear a recommendation, and we're not used to getting EKGs with SSRIs. So there are some quirks of using clomipramine.
Absolutely.
That are important to know about. Well, Jeff, I want to switch gears a little bit, and something I alluded to earlier, which is the use of augmentation with atypical antipsychotics. There is a literature on this. And also, I believe there's a literature not only on the serotonergic basis for OCD, but also the dopamine may be involved. So it may make sense to add something that is modulating serotonin and dopamine. What are your thoughts on atypical antipsychotic augmentation?
Yeah, this is definitely something that I often do use in patients who are presenting with more of that difficult to treat OCD. So again, this might be an individual who is not fully responding to an SSRI, perhaps an individual who is getting ongoing psychotherapy, and I've verified that it's good therapy, that they're including exposures, and they're still not crossing the finish line. So in terms of mechanistically, I guess as we think about this, certainly we have a lot of evidence for the second generation antipsychotics, which have activity at 5-HT2A. So again, definitely a serotonergic mechanism. And one of the things that we know with many of those atypical antipsychotics is that we saturate 5-HT2A at a much lower dose than what we would typically need for D2 saturation. So again, we're using lower doses here with most of the atypicals when we're augmenting an OCD. But what has always really perplexed me is that if we go into the literature, we have data for some of the first generation antipsychotics as augmenting agents in patients with OCD. Even things like haloperidol, which we don't use as much anymore, but there are studies and they're positive for haloperidol. So I think it's probably important as we think about dopamine to remember that this is really something that can't be looked at in isolation. We know that the monoaminergic systems are intimately related to one another. And I suspect that's something that probably is the way in which maybe D2 antagonism is working with some of these medications.
Yeah, and also, of course, aripiprazole can be effective. And aripiprazole does not have very high affinity for 5-HT2A, or certainly not as high as it is for D2. So I think here again, we're not talking about one pathology or one illness. We're probably talking about, just like with all of our psychiatric conditions, a heterogeneous disorder that really does require this idea of individualizing the therapy. And there are probably some people with OCD who need a little dopamine modulation.
Absolutely.
In addition. So I think hopefully for a lot of our audience, that might be new and might be something that they should consider, certainly.
Absolutely. I think one of the things that does make it a little bit difficult when we look at the studies is that many of these studies are actually adjunctive interventions. Right. And that always makes it really difficult to identify a treatment signal when you're looking at the effect of an additive intervention on top of another intervention that we already know works.
Yeah. Well, Jeff, there's actually a literature on some of the atypical antipsychotics. I'm thinking of risperidone as monotherapy that worsened OCD. So the positive studies were only done, to my knowledge, as adjuncts. Although I believe aripiprazole was studied as a monotherapy. The D2 partial agonists are different animals, to be honest, from the traditional atypicals in my mind.
Absolutely. Absolutely.
Yeah. Well, let's talk about now. Now you've got somebody initiated on medication therapy, and certainly I completely agree. Appropriate psychotherapy is critical. TMS is certainly a very interesting idea, but let's talk a little bit about monitoring our pharmacotherapy here. How do you assess response, and how do you decide how long you're going to wait here before you think about switching or augmenting?
So I really like remission to be the finish line here, the goal of treatment. So I'm not wanting really any significant functional impact. And in terms of, how quickly I'm getting through a trial, again, some of this based on the adult literature, some based on the pediatric literature. In many ways, they converge here. But we know that the bulk of our improvement has probably occurred by week 6 or week 8, which may be a little bit earlier than some of our listeners are thinking. So if I've seen no improvement whatsoever by week 8, that's not just a little bit of improvement. This is no improvement. For me, it's time to switch horses. And so, again, those are situations where I'm looking for another SSRI. The other thing that I think is really interesting here is that when we think about some of the selectivity, I've seen a number of patients who have really done quite well on fluvoxamine, but for whatever reason have not done well on some of the other SSRIs. And again, we could think about the receptor pharmacology of fluvoxamine being a little bit different. For some reason, in many patients with OCD, there are real differences in terms of response.
That's absolutely true, Jeff. People don't realize that the SSRIs do vary with respect to what they're doing in addition to the SRI portion. So they're not all the same. They're not quite as heterogeneous as the atypical antipsychotic class, but they certainly are different. And when you're talking about fluvoxamine, one of the unique properties is extremely high affinity for the sigma-1 receptor. And anybody who's listened to me speak in the past few years knows how in love I am with the sigma-1 receptor. Because
actually, I did not know that about you, Andy.
Well, we're always learning things about each other, Jeff, even though we do know each other pretty well now. As a matter of fact, Roger McIntyre also likes to say he has an unnatural love for the sigma-1 receptor. But
what is it about sigma-1 that does it for you? What?
Sigma-1 is sexy, Jeff, and I'll tell you why I say that to somebody like us who's a little geeky about this. Sigma-1 agonism is anti-inflammatory, number one. Number two, it modulates glutamate neurotransmission, and it also modulates the other monoamines. I shouldn't say other monoamines. Glutamate's not a monoamine, but it modulates the monoamines. So we have a number of different mechanisms here that could certainly be helpful when we're talking about something like OCD, which, let's face it, there may be an autoimmune or even inflammatory component to some of the patients. As we know, neuroinflammation can be involved with several of our illnesses. So, and also there may be a glutamate component, as we know. So,
absolutely. I think we'll see that when we talk maybe about some of the other treatments that have at least been explored for OCD. But I think that inflammation piece is really, really important. Again, we can go back to the fluvoxamine trials for acute COVID, wherein it was hypothesized that it was that sigma-1 receptor that was really doing it.
Yes. Yeah, what you're talking about is a classic study now where hospitalization and death, rates of hospitalization and death were decreased in patients who took fluvoxamine, which is really surprising. And it was kind of replicated with other SSRIs. There was another study with mixed SSRIs. Interestingly, fluoxetine also has some affinity for the sigma-1 receptor, not quite as much as fluvoxamine. So again, your notion of if one SSRI doesn't do the trick, thinking about another one, and I probably would make my second line fluvoxamine, and then I would probably third line consider clomipramine, to be very honest. But
I think our algorithms are somewhat convergent here.
Okay, well, that's good to know. Okay, but let's talk about maybe some newer ideas. You alluded to glutamate, and of course, my obvious question is, what about ketamine or S-ketamine? Is there any evidence there?
Great question. And again, we've been looking at glutamatergic interventions in OCD for, at this point, several decades. You mentioned ketamine, and there's a wonderful study by Carolyn Rodriguez from Stanford, published probably a couple of years ago, probably more than a couple of years ago now in the American Journal. There was a nice randomized controlled crossover trial. So she used a single infusion of ketamine. And what she was able to demonstrate with her colleagues was that there were reductions in OCD symptoms within about 30 minutes, and they actually lasted for up to 7 days. Now, in terms of discussions that I've had with Dr. Rodriguez, it does sound like for some patients they did last longer, or improvements were more sustained. It was just that was one of the endpoints of the study. But I think that this is a really important study because it suggests that directly modulating glutamate, and maybe to your earlier point, enhancing neuroplasticity, could actually facilitate faster and maybe even deeper changes, if you will.
Yeah. Well, that's certainly an area that needs to be explored. There's also a literature with an older medicine called riluzole, which is thought to be a glutamate modulator, although I don't know that that's ready for prime time at this point. There was a medicine in development. I did a study with this medicine that was a prodrug, I believe, of riluzole for OCD.
Certainly there is, and there are several studies on that. And people have also looked at D-cycloserine. In many cases, they've looked at this to augment that exposure-based CBT. People have looked at lamotrigine, other interventions that have some glutamatergic component, or maybe flavor, if you will. But it's interesting because there's a lot of failed trials when you look at the glutamatergic modulators, and I think that probably relates to that heterogeneity that we were talking about. To go back to the serotonergic well here, one interesting medication that I don't know that I can surprise you with anything, Andy, but I'm going to try. Ondansetron, so Zofran.
Oh, boy.
There are actually several studies that have looked at this. Did you know this?
I did actually, and I'm going to blow your mind with something else before your
someday
time.
I'm going to surprise you.
Go ahead.
So in any event, these small trials have actually demonstrated some significant improvement, and this is with augmentation of an SSRI. Now, probably important to remember here is that these are not necessarily the nausea doses. These are much lower doses, so around 4 to 8 milligrams per day, not per dose. Interestingly, it seems to be well tolerated and probably does dampen some of that overactive cortical input to that corticostriatal thalamic cortical loop that we often talk about in OCD.
That's right. Well, 5-HT3 receptors are involved with regulating glutamate neurotransmission, so it comes back to that. And boy, is that rational, Jeff. If you think about a little bit of ondansetron with an SSRI, one of the most common side effects of SSRIs is nausea. So that is a super rational polypharmacy, in my opinion.
It is.
Okay, here's where I'm going to potentially blow your mind. Ondansetron was originally studied for depression and schizophrenia before it was ever studied for nausea. It was before your time, but yes, that is true. I know the woman who ran those trials, actually. So, at NEI, we are very interested in digital therapies, and I know that there are some digital therapies being looked at. So that's an area that we need to stay tuned. Part of the issue is, Jeff, you and I have talked about this before, there just aren't a lot of people doing research in anxiety disorders in general, and certainly less in OCD subset of whatever we're going to call these disorders. So I have a feeling that there's a lot more that we need to learn, and I wish we had more research. Because I want to be optimistic here. I like being optimistic about the future and about our treatments. But I guess what we're saying to our audience, Jeff, is to please really maximize the use of the tools that we do have that are evidence-based. And I think we're giving people some ideas here. What do you think?
I think absolutely. Like every other area in psychiatry, and for that matter in medicine, we need more research. Most of our treatments don't get most of our patients across the finish line. Yes, they can be incredibly helpful in terms of relieving distress and relieving symptoms, but oftentimes our patients are left with residual symptoms. And I think OCD is, in many cases, like depression and generalized anxiety disorder and schizophrenia and bipolar disorder in that regard.
Yeah, I really agree. And earlier you referred to remission, and then you talked about functional remission. And I wonder if total eradication of symptoms is always realistic. I think we probably should I think we should focus more on function. And I like the idea of functional remission as being a very more realistic goal. We all have, to some degree, and in certain situations, we get a little obsessive or a little compulsive. So I don't know that the symptoms by themselves, if there are some residual symptoms, is necessarily
I think that's really a great point. I think this is something that we probably should talk a little bit more about in psychiatry. And as you know, I often focus on anxiety disorders. I guess that includes, or maybe doesn't include, OCD, depending. But when we think about anxiety, I will have patients that come into the office and say, I want to get rid of my anxiety. And that just is so disturbing to me. And we kind of do a full stop right there and kind of talk about what anxiety is. And, when we're talking about anxiety, we have to remember that this is a normal human emotion. And for you not to have anxiety before prom or before the ACT or your driving test or a date is abnormal, right? Or maybe I shouldn't say it in those terms, but having some anxiety is normal, just like being able to experience sadness with a loss is normal. And I don't want my treatment to take away someone's ability to experience normal anxiety or normal sadness. In other words, I'm not wanting an anesthetic here. So taking that back to OCD, we know that ordering or being very organized, or what some people might call obsessive, can be a normal functional trait or characteristic. Coming back to development, ordering things and collecting and arranging is developmentally appropriate for many 4 to 7-year-olds. This is something that they do. We think about this as mastering an important task.
Yes, it's adaptive. Absolutely. No, I strongly agree with you, Jeff. We don't want to create robots. I mean, emotions are they're part of the human experience, and they're necessary, as you said, to adapt to certain situations and to deal with grief and loss, to warn us about things. And as a matter of fact, one thing people complain about sometimes with SSRIs is emotional blunting, which is
absolutely
kind of sense of loss of those emotions. So I think I'm glad we talked about this. Jeff, are there other kinds of therapies that people are thinking about?
Maybe let's not say therapies.
Oh, okay.
Because I think that implies an evidence base.
Yes.
But when we look at what our patients are using to try to attenuate maybe symptoms of OCD, you know what I'm going to say, Andy. It's cannabis.
Well, it's either cannabis or psychedelics. Those are the two hot ones.
Right.
Yeah.
And many of our patients, many of my patients will report, that they are using cannabis and that they may experience some subjective improvement in OCD symptoms and perhaps in sleep or in some other associated symptoms. And I think it's probably important to talk about what that actually means. So when we're talking about acute cannabis use, there are some really nice studies. What they do show is that there can be an acute decrease in compulsions and intrusions. But what happens is that tolerance very, very quickly develops. And also what we know from other studies, which have failed to demonstrate improvement in some of those core symptoms of OCD, is that over time, we actually get worsening OCD. But I think, as you know, I'm someone who has training in clinical pharmacology and works with a lot of really talented clinical pharmacologists. And so one of the things that I'm always looking for is a dose-response relationship, because that gives me a little bit more confidence in perhaps what I'm seeing. And we definitely do have that with regard to cannabis and OCD in terms of the worsening, but also in terms of reducing the dose. In other words, stopping the cannabis is associated with more remission or greater probability of remission in our patients with OCD.
Well, that's an important point then. One of the things we need to do when we're assessing and treating is to work on minimizing the use of cannabis in addition to whatever therapies we're instituting. I think that's a very important suggestion.
Absolutely.
Well, Jeff, as we get to the end of our time now, let's see if we can put on our educator and clinician hats and help our clinical audience. We have a lot of people who are not clinicians, by the way, who listen to our podcasts. But for those who are clinicians in the audience, how would you sum up here? What would be your take-home points for dealing with OCD? I mean, assessing, dealing with, managing, what would be the take-home messages here?
So a couple points. I think first, as we talked about at the beginning, this is a disorder. It's out there. It often is hiding in plain sight, either because of comorbidity or because it's presenting with secondary depressive symptoms or anxiety symptoms. I think in terms of other take-homes, I would like for folks to consider therapy, but good therapy that prioritizes those exposures. And from the pharmacologic side, I would like for folks to start with an SSRI and perhaps try 2 SSRIs, maybe that second one really being fluvoxamine. But I'd like for them also not to forget about the TCAs, or specifically one TCA, clomipramine. If we're to talk a bit about clomipramine, just as we summarize here, I want people to know a couple of things. One is that they need to be checking those EKGs, especially in pediatric patients and in adults over 50. And they really need to be getting therapeutic drug monitoring. So clomipramine and a norclomipramine level, that's a 12-hour trough. And then the other thing that I'd probably like for our listeners, particularly the clinician listeners, to take home is that when people are getting CBT, it's really important to ask those questions about what's happening in the therapy. Not just is the patient getting CBT or is the patient getting therapy? Because everybody says that they're getting CBT, regardless of what they're actually getting.
Right. Yeah, so it's important to find some skilled therapists, some appropriate therapists who can specifically treat OCD, not just a CBT therapist in general. That's really helpful. I think one thing I would add, Jeff, is to really try to individualize your assessment of exactly what this patient's bringing to the table as far as their obsessions and compulsions and how it affects them, so that you can really more accurately monitor your treatment and see, are you really making a difference on the kinds of symptoms that matter to this patient and ultimately to their function. So individualizing your assessment, your monitoring, and your choice of treatments, I think is really one way to think about it.
I think that's so important. And I know we probably shouldn't bring in new material here in the wrap-up, but to come back to an earlier point, assessing the patient's insight and really working to improve insight is one of the most important predictors of response, both with regard to psychotherapy and pharmacotherapy. So again, I think paying more attention to those predictors of treatment response, including insight.
I very much appreciate it. I'm glad you brought up insight. And speaking of insight, I'm aware that we are at the end of our time, Jeff. As always, the conversation just goes by so quickly. And I hope those of you listening found this to be helpful and valuable. And for more information about our many other podcasts, you can go to our website and our other educational offerings. And our website is neiglobal.com. And our NEI Psychopharm podcast can be found anywhere that you get your podcasts. So I'd like to say thanks for listening. Please join us for our other podcasts. And Jeff, thanks so much. This was terrific. I really appreciate your time.
Thanks for having me, Andy. This has been my pleasure.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.